Hi, my name is Dr. Kimberly Brown. I'm a pediatric psychologist at Golisano Children's Hospital in Rochester, New York. I'm here today to present a feeding presentation on education and assessment of behavioral feeding disorders. I've been a psychologist working with children with feeding disorders and their families for over 25 years, and I'm really happy to share with you the things that I've learned about how we work on managing behaviors with feeding. So I'm going to share my screen with you now, and we will get started. All right, like I said, we're going to talk about the education, assessment, and treatment of feeding disorders. The Strong Center for Developmental Disabilities, or the SCDD, is one of 67 university centers for excellence in developmental disabilities and is a member of the Association of University Centers on Disabilities, or the AUCD, which is a network of interdisciplinary centers advocating policy and practice for individuals with developmental and other disabilities, their families, and communities through research, education, and service. At the University of Rochester, we are housed in the Division of Developmental and Behavioral Pediatrics, although SCDD includes people of all ages with developmental disabilities in its programs and services. We believe that people with developmental disabilities have the right to live fulfilling and independent lives as active and fully participating members of their communities. The Department of Health New York State Systemic Improvement Plan has been aimed to improve family-centeredness in early intervention. Just a few housekeeping rules for today's webinar. Note that there are 10 webinars, September 2019 through September 2020. Webinars will be recorded and available for viewing through the SCD website and on our YouTube channel, which is Pediatrics URMC. To receive a certificate of completion, you must complete the satisfaction survey emailed to you after the webinar, and early intervention providers can earn 1 hour of credit towards their professional development requirements as outlined in the provider agreement. The objectives for today's presentation was that you'll be able to recognize behavioral aspects of a feeding disorder, learn to identify different medical barriers that might occur for children's eating, learn several strategies to use with young children, including shaping and reinforcement, and identify different ways to promote collaboration between early intervention providers and your pediatric providers. So what makes up a feeding disorder? We all know that feeding disorders are very complex, and they include a wide variety of variables, including medical concerns, nutrition and diet, behaviors during meal times, feeding skills between chewing and swallowing, and self-feeding. We also know that sensory issues play a really large role in how children interact with foods, and feeding disorders create a general level of overall stress for families. We know that when we approach this, we want to use a biopsychosocial model. It's multimodal. We look at medical, we look at behavioral, we look at their skills and abilities and how their environment affects their eating. And we want to make sure we manage this in a comprehensive way, using, at best, an interdisciplinary model, and even better, a transdisciplinary model, where all of the disciplines are within the room at the same time, providing one care plan. If we can all work together to give one consistent set of recommendations, it really benefits families. So what's the new definition of a feeding disorder? Prior to 2013, the definition of a feeding disorder was simply failure to thrive. It didn't leave any room for any of the behavioral or medical characteristics that we now recognize as being associated with feeding disorders. So the official term, avoidant restrictive food intake disorder, or otherwise known as ARFID, really accepts sensory issues as they relate to feeding. It looks at fear of food or anxiety surrounding new foods, addresses food refusal, but also includes medical concerns and nutrition, which it didn't do before. So the diagnostic criteria include a persistent failure to meet nutritional or energy needs with one or more of the following components. So they still include weight loss or failure to maintain weight as one diagnostic criteria. That means that kids are either flatlining across the growth curve, not gaining any weight, or falling down the growth curve, making somewhat of a U shape, or consistently losing weight. We also know that some children with feeding disorders are overweight, and obesity is an issue. They take into account nutritional deficiencies, and so we know that we've seen a number of severe deficiencies, including iron anemia, rickets from no calcium intake, and even scurvy for children with no fruits and vegetables at all, that have very low vitamin C intake. They acknowledge that some children will be on enteral feedings or supplemental formulas just to maintain nutrition and weight gain. But more importantly, one of the criteria is that a feeding disorder demonstrates a marked interference with social functioning. We know that children with feeding disorders have difficulty interacting with their environment physically, socially, and emotionally. It's difficult for kids to go out to eat with family members or at birthday parties. We know that school lunch can be very challenging for children with feeding disorders. And so that also allows us to not have medical symptoms, but still have a feeding disorder. Sorry about that. The other part of the diagnostic criteria is the exclusionary information. So we know that feeding disorders are not due to lack of food or cultural practice. So if families have food insecurity, and that is what's guiding their feeding disorder alone, we know that that is not diagnosed as ARFID. We know that feeding disorders do not occur in the context of anorexia nervosa or bulimia nervosa, so that eating disorders and feeding disorders are two very separate entities, and it's important to note that their signs and symptoms are strikingly different. We see more eating disorders related to mood dysregulation, to body image issues, where feeding is more related to sensory, behavioral, with children with disabilities or learning disorders. Any food issues that arise out of depression or anxiety is not considered ARFID, as more related to other psychological issues. One of the exclusionary criteria is that it's not due to concurrent medical condition or a mental health disorder, unless the severity of feeding concerns exceeds what is typically seen with that condition. This is really important because in the past, if you had reflux or were on a G-tube, that was an automatic exclusion from having a feeding disorder. However, we know that if you have chronic vomiting and we're attempting to manage it, and it's still not going away, and it's significantly impacting your eating, those medical conditions can count as having a feeding disorder. And so we want to look more closely into what some of those medical conditions would be. So reflux or chronic vomiting are the most common that we see, and there's plenty of medications that have been used to try to monitor those, but sometimes they're still uncontrollable. Food allergies have a significant impact on children and their eating, and we see significant declines in intake for children that have had significant aversive events while eating. So having anaphylaxis while you're in a restaurant or at school, having to start to avoid foods leads some children to avoid other foods as well, even foods that are safe. Eosinophilic esophagitis is something we'll talk about in a moment, but it's basically an internal allergic reaction within the esophagus that causes some significant feeding issues. Delayed emptying, where food doesn't move quickly enough through their intestinal tract, can lead to food backing up, can lead to constipation, can lead to reflux, bloating, a lot of stomach and abdominal pain. Children, like we said, who are NG or G-tube dependent. This would also include swallowing dysfunction, dysphagia, children who have aspiration and frequent upper respiratory infections. All of these things can create oral aversion that significantly impact where to go. It's really important that if you suspect anything like this, that you make an appropriate consult to a GI physician or back to their local pediatrician for further evaluation. We should never attempt to diagnose these things or treat these symptoms outside of our scope of practice, but rely on your pediatric and medical providers to be able to take a closer look. You should be looking to recognize some of the symptoms so you can make a good referral though. So what is eosinophilic esophagitis, or EOE? We see this in children 2 to 3 years and up that are still on purees or just formula, children that are having trouble moving across that developmental food continuum. We see children who are drinking excessively while eating as if they're trying to help themselves swallow. Choking or difficulty swallowing. Food impaction is something we see in older kids, though I've still seen it in young kids too, but foods like bread and rice and meat tend to be especially difficult for them. Kids with eosinophilic esophagitis have reflux also. And then we also notice that there are other allergic conditions that these children have, which could include eczema, asthma, food, or other environmental allergies. All right, so getting back to our definition of ARFID, there are certain avoidance responses that children have related to food that occur even before food gets into their mouth. So they show a lack of interest in food or eating. They don't seem to care what you're eating. Your food's not interesting. They don't show any hunger signs. Some kids are really concerned about what will happen if they eat something new. It's going to make them sick. It's going to taste bad. And lots of kids avoid food based on their sensory characteristics, how things look, how they smell, how they feel when they touch them, or how they feel in their mouth. Food selectivity is one of the major issues that we'll see in children with feeding disorders. This one is probably one of the primary issues that we see. And kids get very, very selective based on minute characteristics around food, brand and container being this most common one, where children are only addicted to one brand of things. So McDonald's chicken nuggets, Go-Gurt that comes out of a tube. We notice that these kids will notice the container or be able to detect very small changes in different brands. They get really stuck on food preparation, who cooks it, where it's cooked, how it's cooked. The visual aspects of food. So if you look at the pancakes in this video, they are a little bit burnt on the outside, and that color brown is going to deter kids from wanting to try them. Or how it's presented. Notice that the fruit is touching the pancakes, and that's really going to cause some issues. Food refusal comes as a result of being super selective, and it generates a lot of anxiety. And so we get our focus is more narrowed with what we like when we're anxious about what's being offered. So we used to think that there was a specific diet for children with autism, right? Dry, white, crunchy, bland, salty foods. This was a pretty common thing that we would see. Children with autism would tend to be moving right along, eating a typical diet, and then when their diet reduces, it comes down to these specific categories. However, over the last 25 years that I've been working with feeding, this is not strictly related to kids with autism. We see this across a wide variety of populations of kids across different ability levels. I think that we are a carb and dairy heavy society, and we focus on prepackaged foods. Prepackaged foods always taste the same, and there is a high level of consistency with them. And our children, again, can tell the difference between brands. And so this is just this part of selectivity that we really have to work through. Flavor, color, texture, all of those issues come together for us to figure out how to move forward. Another part of feeding disorders are the food refusal behaviors that we see. Some are very common. They'll push food away, they'll turn their head, they'll cry or scream. We get more disruptive. They're throwing food, they're running away from the table. Failure to sit is one of the biggest concerns that we have, and also holding food in their mouth. Packing, that's the most difficult behavior to observe, especially when it's behavioral and not an oral motor issue. When they're doing it just to avoid swallowing. We know that that is very challenging to treat and poses quite a concern. But recognize that if food refusal is really high, you're not going to be able to address oral motor skills. You're not going to be able to address self-feeding if their refusal for you to come near them or to do any guidance or participate in any oral motor activities is going to be disrupted. And we can't try new foods if we don't sit. So sitting is a really, really important first skill that all of these children have to be able to master. And it's important as you're working in the homes to be able to notice the sitting environment and to work very diligently with parents on getting their kids to sit, even for short periods of time. Next question that we talked about with those behavioral avoidance behaviors is whether or not kids recognize hunger. We see some of these responses that we think children associate with not feeling hungry. So they don't really show interest in your food. They don't tend to ask for food. They can go for long periods of time without requesting food. They don't eat when they do request food. So they ask for crackers, but maybe they eat just a few bites and they're all done. We also see this in kids who are snacking frequently throughout the day, just eating little bits at a time as they go. What does hunger feel like? We wonder how kids experience hunger. For kids that can tell me, sometimes they can tell me their tummy grumbles, but what are things that they might be experiencing? When we have hunger pains, does that mean that they shouldn't eat? If they're refluxing and they feel nauseous often, maybe that kind of deters their hunger. Maybe they always feel like that because they eat such little food at a time and they don't recognize that putting food in their belly means they're going to feel better. We know that kids that graze and snack all day take the edge off their hunger. They eat just enough so they're not feeling hungry and not feeling full. And this causes them to be disruptive with what their systems are like. And they can do that with solids as well as liquids. Milk fills you up very fast and can keep them going throughout the day without eating solids. And we know that oftentimes when there's no scheduling or structure to meal times, that kids are left to try to regulate their own physiological body clocks, and that's really not a good way for them to learn. We also know that kids who are in tube feeds have a really difficult time being able to regulate their hunger. What are some neurodevelopmental and behavioral issues we have to make sure that we pay attention to? What's their developmental in relation to the skills that we're trying to teach them? What can they understand that we're asking them to do? What are their oral skills like? We know children that miss that critical period for learning some of these skills have a much harder time moving forward. And so we need to be conscious when working with them behaviorally on what their skill level actually is. Of most importance, we always want to protect their airway and make sure that they're safe. We know that kids should be seated appropriately, 90-90-90, feet flat on the floor, so that it kind of benefits their chewing and their swallowing. It benefits their tone and their ability to maintain trunk control during meals. They've got to be able to coordinate their hand to mouth for working on more independence and working on self-feeding. And kids need to be able to be encouraged during meal times, to have interactions with new foods and different activities, but also have opportunities to engage in these things. And I've learned over the years from the wonderful OTs and speech and PT folks that I've worked with that breathing has to come first and positioning second before we get to eating. So we want to make sure as behavioral therapists that we pay really close attention to all of these issues, things that you're probably very conscious of on a daily basis. So what's the difference between being picky and having a feeding disorder? A lot of times people tell me, well, they just said my kid's a picky eater, but we know there's differences. If you're trying to tell the difference, there are a few things that you can look into to determine whether or not it's warrants, severe. It's severe enough to warrant extra attention. So we know with food groups that most kids are not eating vegetables very well, but we also see in our kids that proteins are lacking, which can lead to iron deficiency anemia, and also fruits. 50% of our kids eat fruit and some don't. It's a sensory experience with texture and consistency, and also fruits and vegetables with their ripeness makes a difference. We already talked about branded container, because picky eaters can eat any kind of mac and cheese. Kraft has really ruined that for us. That's the cheesiest and the best. If you've seen the current commercials where the child's refusing broccoli and they feed them Kraft mac and cheese and everything's better, that really goes against everything behaviorally that we try to teach. We know that textures can be an issue, that picky eaters tend to eat a variety of textures, but our kids tend to prefer purees or crunchy foods, and mixed textures tend to be really difficult. And that's not always the case, but you might see that in the kids that we see. Again, food refusal will be significantly higher for feeding disorders than for picky eaters. Eating socially and in public is a huge indicator. Most kids can go to a restaurant and find something to eat when they go to their friend's house or go to birthday parties, but our families are bringing food from home, they're eating before they go out, or they don't go out to eat at all. Our kids are also having a really hard time eating lunch in preschool and daycare and all of their schooling, so that we know that those feeding concerns are really high. Their influences are picky eaters, can eat to get their, eat their peas to get their ice cream, to get, because their friends are doing it. I've seen my friend trying, so I might be more likely to try. But again, our kids aren't interested in what you're eating, and rewards don't matter to them. You cannot offer them toys, money, anything to be able to get them to try something they really don't want to try. And again, mealtime stress are going to be much higher in children with feeding disorders. So what are some of the common feeding problems that we see? We've talked about a lot of these issues, and we'll talk about some ways to address them today. But again, not only is it complex across medical, behavioral, sensory, and skill, there's a lot of different goals that you can address during feeding as well. Low intake, variety, selectivity. How do we disrupt their rules and rituals? Kids that are very stuck on how to eat it in a certain way. That's really important. How do we look at anxiety and parent-child interactions during meal times too is another important goal. So I'm going to tell you a little bit about our pediatric feeding disorders program here at the University of Rochester. We have a transdisciplinary team of psychology, a dietitian, and a speech pathologist. We all work together to provide one plan to families, and it's very important that we provide that comprehensive care. During our first visit, we'll do a parent intake where everyone comes together and get as much information regarding the child's eating as possible. We want to make sure that we have time to build rapport with that family, and that they give us all the information needed. And we're going to look at all aspects of their feeding, from medical to their diet, all of their skills and abilities, behavioral environment around food, and specific behaviors related to eating. At the second visit, we'll do a child interview if they're old enough and it's appropriate, and then we'll observe a meal fed by their family, just to give us an idea of what strategies parents use, how their children respond, and how they react across a number of different food categories. We usually ask families to bring preferred foods, to bring a new food that they would like to see their child eat, that they would want to see them eat something that they used to eat but have lost, and also food that's very similar to something they like but different in texture or brand, shape, color, flavor, something like that. Our treatment room is nice and small. It's an easy place for us to eat. We're very well equipped with different seating arrangements, tables and chairs, utensils, so that we can try to simulate what looks like a kitchen to the best of our ability. But notice there's not a lot of distractions. It is still a little bit different from the home environment. This summer, with the pandemic that we're in, having been able to do things through telemedicine and have families show us how their kids eat from their home environment has been very, very helpful. I think that's such a benefit. You have an earlier intervention is actually to be in their homes and see firsthand what that environment looks like, because that's a crucial part of intervention. Now, after we do our child observation, we've decided that it's really important to start with the parents, that they're going to be the agents of change at home. They're the ones that we expect to implement these strategies with their children. And we've noticed that often when they bring them into clinic to see us, their goal really is for us to fix the problem. They want us to make everything better and think that it's going to miraculously happen at home. And we know that that's not the case. And most behavioral parent training happens at the end of treatment, and it usually happens when parents are not in the room during therapy. And we always function with the children and parents together. Very rarely will we see a child without the parent present. So we start, before we even get to therapy, with 3 parent education visits. And those sessions across a variety of different topics. First, we're just going to help them define feeding disorders, understand what they are and the impact that they have. And we work on scheduling and structure and sitting. How do they set up their home environment to make it the most conducive for us to start therapy? I think this is a very important place to start, and you have a really strong role in being able to do this when you're at home with them. The second education session is what I call how we think, talk, and act around food. It's a way that as a therapist, I tend to approach eating. We talk about appropriate expectations for pace of progress, for nutrition, for how that we're going to move forward. We talk about how we use positive attention and positive interactions around meals, that we talk appropriately about food. we avoid some of the pitfalls that we fall into when we're trying to convince our children to eat. And we talk about adaptations that families are making around food when they're jumping through hoops, going a little bit too far to try to get their kids to eat. How do we bring that back down to something that's much more manageable? And in the third session, we talk about motivation and reinforcement. How do we actually make it work? What is the reasons that reinforcements fail? And how do we make it work for each individual child? And how do we develop a plan that's going to be comprehensive enough that we'll actually see some progress? Now, if parents are successful, if they participate, we give them homework and things to practice. If they can show us that they're working on these things and making progress at home, then we'll initiate feeding therapy with them. Now, there are certain skills that children need to be able to participate in behavioral feeding therapy, and we kind of assess these as we go. They need to have some attention span to the task. They need to be aware that food is present. They need to be able to engage with it on some level, even if it's only for a few minutes at a time. They need to be sitting to be able to practice. We need them to be able to follow simple one-step directions. So being able to start, and also being able to start to learn first then concepts, that I need to do something to get something. Sometimes we will use straight distraction. However, that decreases your attention to the task, and it doesn't seem to work as well when we're working on behavioral interventions. We want kids to have some emerging communication skills, whatever that looks like. Pictures, signs, word approximations, being able to follow visual schedules. We want them to be able to start to learn how to appropriately communicate during meals. And for some of our behavioral interventions, we really need these things addressed first. And these are things that through early intervention, you're probably working on already, and may notice that you need to work on these skills before they're going to be able to start be willing to put food in their mouth. So this is really an important place that we consider starting. Now, there's a stepwise progression that I go through in terms of introducing kids to new foods. First, again, we start with the environment and schedule and structures and offer families as many visual supports as they need to provide that structure at home. Cooperation has to come second. So they've got to be able to reduce food refusal, to increase their motivation and reduce their anxiety around new foods. And this usually has to come before skill development, like we said earlier. If your food refusal is too high, you're not going to be able to learn any of the skills that you need to feed yourself or to learn to chew and swallow better. After that comes tasting and trying. So getting food to your mouth is the third step in this progression. And so notice that families have to understand it's going to come later. It's not going to happen right away. Once they are tasting and trying new foods, then we'll be able to get in better volumes of the things that they like, that they've tasted. And once a good volume is consumed, then we can add it into a mealtime. It's really important to me that we follow this progression and make sure we don't try to go too quickly, because the goal is for children to find foods that they like, to start to enjoy those things, and to feel better about tasting and trying new foods. If we go slowly in a nice progression, we're going to get there a lot quicker than if we jump in too fast and make things too difficult. All right, so make sure that you're prioritizing your goals when you start. Pick a few that are reasonable, that the child can actually do, and that they can attain. So if your therapy list is 8 weeks long, it's not that they're going to eat a full diet from all the 5 food groups. It might be we taste and try 3 to 5 new foods. It might be that we sit at the table, or that we have structure around meal times. Think about what's reasonable given the time that you have with them. And when that time is up, if we need to establish new treatment goals, we need to go further with therapy, or maybe we've reached what we need to reach for that time. But just make it attainable for the parent and the child. It's really important that we keep that in mind. There's a lot of different behavioral interventions that we can implement, and we're going to just talk about a few of those today. But we also always want to make things really fun. We want to set up good mealtime routine at home. We want to use reinforcement so that things are positive and motivating. Shaping and food chaining are strategies we're going to talk about today. But disrupting rituals is important. Having to eat more than just the whole goldfish. They've got to eat the broken pieces too. That we don't just take the cheese off of our pizza or just lick the cream out of the Oreos, that we have to work on eating the whole thing together. We do some cognitive behavioral strategies for anxiety reduction in some of our older kids. And we'll also talk about generalization today because it's really important that whatever we teach children, their families are able to do at home and in other settings and for other caregivers. Okay, so how do we make meals fun? One of the first things I tell parents is to take all the pressure off of dinner. Dinner is the hardest meal of the day. It's the most stressful for everyone involved. And I tell families that we're not trying new foods at dinner. We're going to pick a snack time where we have 15 minutes to dedicate to something new, and we can work on getting that child comfortable and getting that food into their diet. When I take the pressure off of dinner, 9 times out of 10 families tell me it already feels better just by not trying new foods at dinner. Sometimes it feels like the child is winning because we're going to offer them what they like at that mealtime. But really, we're going back to baseline. We're going to establish a non-stressful situation and then slowly build back up. Again, I don't believe in jumping right in and making anything too difficult too fast. We want kids to be able to participate and enjoy the process. We let children make choices when it's appropriate. I give them choices over what we have in the house to eat. We want to make sure that we're not talking in a lot of negative ways about food or trying to coerce them into doing something new, but we can engage in positive interactions, talking about what the food is like, identifying sensory characteristics, looking at same and different, trying to help them be able to understand what the properties are of the foods that they like, help us develop their preferences. And I usually ignore minor whining, complaining, minor disruptive behaviors. It's not something that's worth giving extra attention to. If we spend more time focusing on their good behaviors, we're going to see less negative behaviors. We established some basic rules at mealtimes. Eat what you ask for is really important. If you told me you want mac and cheese and I make mac and cheese, that's what's for dinner. I don't want families to be short order cooks where they make mac and cheese and they say no, so they make a hot dog and then they say no, and they end up giving a snack or cereal or crackers because that's really what the child wanted in the first place. We have to work on providing what they ask for. You have to be cautious and aware of young children that are bad choice makers. So if they tend to pick things out, but we learn over time that it's never really what they wanted in the first place, or they feel like they've lost something when they make a choice, we need to be assessing whether or not they're really good at choice making, and that may not be a strategy that we use for some kids. I tell kids that we taste with our tongue, not with our eyes, so visual discrimination does not become their rule with how they taste, but tasting only happens when we taste with our tongue. Again, we have positive talk at the dinner table. I like the family to stay seated together. If one child gets up and is done early, and there are other siblings, they're going to get up early too. So trying to promote the family sitting together, even if we have to, shrink mealtime so that it's a little bit easier for everyone involved. I love kids to be a part of preparation and cleanup. It's really important to engage them that way. And I post those rules and I follow them. I remind kids what they are, remind all the family members what they are. It increases consistency and predictability. And we know that kids thrive on that. So being really consistent with how everyone interacts around mealtime is going to make things much easier. So how do I make mealtimes easier when children have a lot of refusal behaviors? I want to teach them appropriate ways to get out of eating. Okay, instead of screaming at me, we're going to use appropriate words. Please, I need a break. I'm all done. No, thank you is my favorite. I'd much rather a kid says no, thank you than scream no in my face. Right? So we want appropriate ways for them to refuse. Maybe they need a card that says all done. Maybe they need the sign. Maybe I need a timer so that they can have movement breaks. I have a kiddo who really can't sit. It's not because he doesn't want to be around his food or because he's trying to refuse. It's just, it's too long for him to sit. So he gets a break if he needs it. I think breaks are really important as long as we know that the kids will come back to the table after their break. If they get up from break and never come back, then break's not a good idea. And I can reduce the demands. I can make things easier. Maybe I ask for a less number of bites. Maybe we do fewer trials of tasting something new. Maybe I give them something easier to do. So instead of taking a bite, I just ask that they lick it. Worst comes to worst, I back up to you need to clean the table and put everything back in the sink. Find a way that you end on your terms and you end on a good note so that refusal isn't what kids learn to end meals, that they need to do something positive and appropriate to be able to say no. All right, so this is the most difficult and the most important strategy that you're going to help families with in establishing structure. It's what I call the positive mealtime routine, and it means that meals and snacks happen at the same time every day. We need to help them learn what their hunger satiety schedule is like. They're not allowed to graze during the day, no snacking in between scheduled times, no milk all day long that's out and available. Water, low calorie beverages are acceptable and promoted because we don't want dehydration. In between meals and snacks, when they're bored and they're asking for food, it's when I'm going to schedule the most appropriate activities and most highly preferred activities. And this often happens when we get home from school before dinner. That's the biggest snacking time that happens. And if we get goldfish, we're not hungry for green beans and lasagna. So we need to make sure that we save those highly preferred activities for when kids get home from school or during those times of day where they seem to want to snack the most, but they need to wait. We want to limit distractions during meal times, and this is generally an important rule. Some kids need distraction to be able to continue to sit or stay at the table, and so we'll make good decisions about when we do that. But for the most part, we want to limit them. We set time limits, so we're not going to have meals that last an hour or longer. We want to make sure that kids are sitting for an appropriate amount of time. And again, we're going to make it fun and positive. Kids can have no structure and still learn to try new foods. So it's not, we can let families out of this goal, but what I've learned is that if families can do this and they establish good structure, they always tell me kids' intake at mealtime is better. That behaviors are better because they're hungrier, and so they're more willing to eat the foods that are offered. And it helps them make more progress down the line. And it shows that families are invested and really want to make lasting change. So I really encourage to really focus on this strategy first. So the number one problem that I run into with meals is that kids aren't sitting to eat. And this is problematic for behavioral reasons, as well as for safety reasons. So many of our families get desperate with these young kids with poor chewing and swallowing skills that are letting them walk around the house with goldfish when they're really not chewing them, where choking becomes such a high risk. And families that are desperate and their kids eat very little will avoid this risk. They will continue to let them eat wherever they want because they think that's the most important thing to get them to eat, or they're chasing them around the house with food. We really have to work on eliminating those things. That safety and appropriate mealtime behaviors are much more important. So we'll designate 1 to 2 places that it's okay to eat at. Remember that some families may not have tables. Some families eat on the couch as a family, and that's where they eat. We have to accommodate them. But if we're working on self-feeding or we're working on interaction, at some point, kids going to need to be seated at a table where they can appropriately do these things. Help families identify appropriate seating for their child. We may need them to get back in the high chair or the booster seat again. You know, when they're 2 and families want to get rid of it because they want to sit like a big boy at the table, but now they're running around the house in between bites, we really might need to work on getting them seated in the chair. What if they don't like the high chair? Well, we're going to practice sitting for preferred foods in play. If you really want your chips, you've got to eat them in the high chair. We're going to play with your most preferred food while you're in with your most preferred toy while you're in your booster seat. And we can use timers so that we start with a really small period of time, 2 minutes. Timer goes off. The timer indicates when you're done, not your refusal, not disruptive behavior. And we can reward sitting. We can use technology to help kids sit. I don't tend to use technology during meals unless I absolutely need to. And if the only way you'll sit is with your iPad, I'm going to use that to start, because over time, as you get better at sitting, we'll be able to fade that out. Sitting is really important. All right, so myth or fact? Do we offer preferred foods as rewards for eating non-preferred foods? We call this Premack principle or grandma's rules, the old misnomer for this. So we need to eat your salad and then you can have your ice cream. My short answer to this question is no, that more often than not, this is not an effective strategy for kids with feeding disorders. There are multiple reasons for this. One is because oftentimes it depends on how aversive the food is that we offer versus how good the reinforcer is in food. Many kids will bypass a preferred food if they think the new food is gross enough or something they really don't want. So I would not be inclined to eat salad to get ice cream. That would not be something that I would want to do. Broccoli, I could do that. It's not as aversive to me as salad is. That's my own feeding disorder issue. But ice cream is very important to me, and I'm willing to do a lot of things to get it. Another reason we tend not to do this is because in general, we just don't want to use food as reinforcers for other foods. What often will happen, especially if children have a very low diet, is that they'll start to drop foods out of their diet if they're only contingent on eating something new. So you have to be really careful with what you use if you use it. I will use it as a last resort if it's all I have, but in general, I'm going to avoid food as a reinforcer. So how do we use reinforcement? We need to use it because kids are not typically motivated by the food itself. It's not intrinsically rewarding to them like it is to us, especially those kids that are not experiencing hunger. And we know that they need extra incentive to move forward. We want them to learn that trying new things is fun and results in good things. And that's why we pair positive reinforcement and motivators with trying new foods. And again, we hope that over time, that as they learn to like new things and feel more comfortable trying new things, that we can fade reinforcers out. But usually is an important place for us to get started. You usually need reinforcement on a consistent basis to learn a new skill, and it can become variable once we do learn the skill and it becomes a habit and part of our repertoire. There is a notion from Ellen Satter called the division of responsibility. And this theory notes that parents are in charge of what foods they offer their children, and children are in charge of what they put in their mouth. And that's absolutely true. We don't promote force feeding. We want to make the environment positive enough so that children want to engage and want to try. However, this also means that there's no praise or reinforcement provided for eating, that there should be no attention or notice brought to it. This really suggests that exposure only is going to be the strategy that works the most. And she even notes that it doesn't matter if the child ever acquires new food or it takes until they're grown up to try a vegetable. Obviously, if kids have come to us, that's because exposure hasn't worked, and families are feeling like it's important for their children to acquire new foods. So I feel like this is not a reason not to use reinforcement. So how do I use it? I use it in layers all throughout practice time. Before the snack, as they're helping us prepare, we'll make it fun. So we might have a game or a toy present while we're trying something new. Maybe afterwards we do something really fun because they cooperated. I use charts and checklists for parents and for kids to help document their progress. And also note that we've got to change reinforcers often, that kids get tired of the same thing over and over. But the more we layer reinforcement and positive activities, it's going to help reduce anxiety and refusal. Distraction always makes anxiety better, especially in young children. And that's why it's important that we consider these things. There are certain characteristics in reinforcement that you have to be aware of, things that are very important in order for kids to be able to follow through. They have to know exactly what to do. They need specifics about the exact behavior they should emit and what will happen if they do or don't. So we need to touch the carrot 5 times, and when you do, we can play with cars. If you choose not to touch the carrot, we won't play cars. Simple and direct, touch carrot and play cars, no touch, no cars. You can make it as straightforward as you want to. You can use visuals, so there can be pictures or first then boards of what they need to do. You can use actual items and modeling to help them know exactly what they want. It should be an easy thing for them to complete initially, and the reinforcement should happen right away as soon as the behavior occurs. No delays in offering a reinforcer. We don't want to keep it too far apart in time because kids forget what they did and why they earned it. And also the last 2 pieces are really, really important. Kids have to earn the reinforcer or get it if they earn it, and they can't get it if they don't. So you need to make sure when you're using reinforcers that there are things that you can withhold if children choose not to participate. I don't say you can play with all your toys because I can't restrict all their toys if they choose not to participate. You pick one thing, that's what we withhold. You want to make sure it's valuable and worth their effort to earn, because they need to be able to buy into the program. If it's not valuable to them and they never earn the reinforcer, it's not going to work. If they never contact the contingency that I did something to get something, then reinforcement isn't going to work. And but it's because of the value issue. And it's going to be if you're able and capable to follow through. When your grandma said, I'll turn the car around if you don't stop horsing around, we knew they weren't going to do that. We knew we were going to Disney World and we were still going to get there no matter how we behaved in the back of the car. We don't want to provide threats of consequences and then not follow through because kids start to distrust what we say. So making sure that you follow through and that it's valuable enough for the child to earn. We also want to make sure that kids learn that your yes means yes and your no means no, right? And so that they're going to be able to trust what you say and know that when you say no, you mean it. And when you say yes, you mean it. It's a really important thing to learn with follow through with reinforcement contingency. Some common questions that families ask me. Why don't sticker charts work? Because sticker charts are not reinforcers, they're placeholders. We use sticker charts just to document progress. And so that kids can be able to see what they're doing. It makes it specific. If I need them to kiss the apple 5 times, then they're going to be able to get a sticker every time they do it. They see 5 spaces. They know that 5 is what I mean and where I end. We know that sometimes rewards work for a little bit and then they stop. And again, that's because kids get bored and tired of what we're offering. So we do have to change what we use. What about when kids don't constantly play with the same thing? So how do we choose reinforcers? We have reinforcer assessments and surveys that we use to be able to help families identify things that their kids prefer the most and how to find those things right in the moment when they need it. How do I choose reinforcers if my kids don't like to play? We often see that kids are more addicted to technology than toys. And it's really important that we start to teach kids how to interact with other things. Now, sometimes we can use unusual reinforcers as rewards. So if they like a fan blowing in their face, if they like bright lights, I have one child that liked to feel the air coming out of the dishwasher when they opened it. So as soon as we finished touching, we went over to the dishwasher. Another big question is, do I have to buy prizes for my child just to take a few bites? And the answer is no. We do not request that families buy reinforcers or toys or prize boxes for their kids to eat, because over time we need feeding to become something that is intrinsic, that they like to do it, that they find flavors and they find preference. Children have plenty of toys at home that we can use as reinforcers. We also want to make sure that the reinforcer we use matches the behavior. So you can't go to Chuck E. Cheese because you licked 2 gummy bears, right? I did have someone say, if you make teeth marks, we can go to the GameStop and buy a new game. That's too big a reward for too small of a behavior. We use bigger rewards for more consistent behavior. So we're trying new foods for a month. We have appropriate behavior at the table for a month, then we can go see a movie together. But we want to make sure that those reinforcers are reasonable. All right, so that's reinforcement. The next one I just want to talk about is this myth or fact. It takes 10 to 20 offers of a new food for a child to learn to like it. So I should put something new on their plate every single day. For me, this is a myth. I think it's 10 to 20 tastes and not offers before we can tell if children like it. Although sometimes you will know right away by a really bad facial grimace or gag. That you'll know right away if they don't like it. When we're using this strategy, we're not working on tasting and trying, we're working on exposure, right? And that is if tolerance is your goal. If we need them to just get used to things being different, if we want to see if they can habituate to a smell, then we are going to put something novel near them and see if they can get used to it. For kids that are running away from the table, that don't like smells or being around things that you have, we will find benign things that we can use to get them to tolerate that situation a little bit better. We may find that there are certain things that they will not tolerate or get used to. We're going to get rid of those foods and try something else. So how do we work on kids trying new foods? So the strategy that we use with the behavioral term is called shaping. And shaping is similar to the sensory oral sequential approach, or the SOS approach used by Kay Toomey, which many of you may have heard of. That's just using a stepwise pattern to get children to experience foods across multiple sensory dimensions. And we use this strategy very similarly. However, we don't wait for them to develop so that they want to move forward. We are going to make sure that we set it up in a way so that as soon as they're successful with one task, we move to the next one. I know that if we let kids decide to move forward on their own, they get stuck. And usually it's between lick and bite. And it really, if we do it really systematically, we're going to be able to work through the steps much faster. And if we combine it with reinforcement, it's going to be really positive. So how do we do that? We teach different responses in the eating chain. And we start with the thing that's easiest. And as soon as they can do it, we're going to move up to the next step. It should be a just noticeable difference. So it's a little bit different than when you asked me before. It's a little bit harder, but it's something I can do. If we go to bite right away, we get lots of resistance, and that's where we come from. And taking a bite is your end goal. This usually does help reduce stress of trying new things. And again, if we organize it and we plan it, it's going to go much more smoothly. So what are these steps to eating that I call them? Well, the first one that we start with could be increasing tolerance, like we talked about before. Next comes interaction. So touching with our hands or using utensils, stabbing, cutting, stirring things, even helping with cooking or shopping in the grocery store can help increase interactions with different foods. The next step comes increasing the food to get to closer to their mouth. So smelling, kissing or touching to their lips, touching their teeth or holding food in their teeth can be one way that we get it closer without having to eat it. And then tasting becomes the next step. So licking, touching it to our tongue, those are different ways they start to taste. And then we move up to bite. So there was a research study done by Kegel et al. Back in 2011 that actually took these steps and did a scientific study. There's been no research on this type of strategy, although many, many people use it. Their hierarchy was touch, smell, kiss, hold in teeth, lick, and then bite. And for bite, they even expanded it further. So they allowed children to be able to expel the bites following different series of steps. Biting right away and expelling right away, holding it, then chewing and swallowing. So they gave kids a variety of ways to go through this procedure. We start with the easiest step they can do, but we also do it a certain number of times to make sure they can do it. So we're gonna lick 5 times, then we can play with cars. And we're gonna repeat that sequence 3 times. So we're gonna lick 1, 2, 3, 4, 5, here's your car. Then we're gonna do that 2 more times. We're looking to see that 4 out of 5 times on each trial, they can do it appropriately with very minimal refusal. We want it to be a rhythm. We want them to know what they're expected to do, and it becomes predictable and it becomes easy. This helps us know how to move to the next step and how quickly to go, again, so they don't get stuck. So here's a study that we conducted to look at these strategies. We looked at pretzels for this young girl. You can see the steps up here for touch, for smell, kiss, lick, hold in teeth, and then accept. What you see over on the x-axis is their percent compliance with each step. So to start, we probed each step. We asked them to touch 5 times, to smell, and to do all the steps 5 times. They did touch very well. Smell and kiss were around 50%, but then they did not lick, hold in their teeth, or take any bites. So we went back and we trained the next step that was at 50%. And we got her to smell easily, but when we went to probe the rest of the steps, she still wasn't able to do them at 80% or better. So we had to go back and train the kiss step, and we had a little bit of trouble in the beginning, but she did very well. On our next set of probes, she licked, she held in her teeth, and she took a bite right away. And we're able to maintain taking bites across those 4 sessions. So this was a way that we were able to test those strategies, to do it quickly as soon as she learned that skill. And what you see with shaping is that the more you practice, this was maybe the 3rd food I think we tried with her. The more you practice, the less steps you need and the quicker you get through. This was only 15 sessions that we were able to acquire this food. So it's a really good way to do it, but not wait for them. You've got to work on moving forward. We did try some strategies with the bite and expel step. The children that we tried it with thought that expelling was fun and a game. And so for this particular child, we did cut that out. You will have to make a determination with each child whether or not allowing them to expel will benefit them or get in the way of progress. Make sure that when you're doing shaping that you're paying attention to their sensory and anxiety reactions when trying. Oftentimes, kids come in and have significant refusal when a new food is presented. But when I pull back and I make it easier, I start to notice that the refusal that looked really purposeful before goes away, and now I'm seeing what their sensory and anxiety reactions are to these things. I see more pulling away from the food, more fearful looks on their face, maybe shaking, sitting on their hands, more apprehension, might see more gagging, grimacing, or flapping. We want those behaviors to go down before we move to the next step. I do have some kids that are having these responses but still want to keep going on. And so if they're trying to experience it and move forward through their exposure, I'm going to let them work through it. But if it looks too difficult for them, I'm not going to push through a sensory experience that I think that they can't participate in. Make sure that you do these steps in order because they are progressive. Back up if the next step was too hard. So we don't want to push them too forward too fast, but don't jump around in the steps. You can probe forward. So if they're doing good with kiss and you want to see what will happen, probe, lick, and bite, just like we did in that study, to see maybe you don't need all the steps with each food. Or once you get to the second or third food, you offer it to the child and say, what do you want to do with it? And see where they start, because you may not always need to start at the bottom as you progress with foods. I model with them whenever I can, as long as it's a food that I like and I can model with them with. And again, be creative. Sometimes between lick and bite, we do touch teeth, hold in teeth, teeth marks, tiny bites. Be as creative as you can in what those steps are to be able to get to where you want to go. The next strategy that I want to talk about is food chaining. This was developed by Sherry Fraker et al. In her book on food chaining. It's an excellent resource. She provides lots of details about children with autism that have feeding disorders. She provides lots of different food chains, some that seem really difficult to me, and some are wildly inventive and creative, but it's a very good book. I highly recommend that. Food chaining is a way for kids to get unstuck from their selectivity. So from brand, from container, from flavor, from shape and color. We can help kids get a bigger variety of one type of food or get to healthier versions of the food that they like. So Go-Gurt to Greek yogurt, McDonald's chicken nuggets to baked and grilled chicken. Maybe they end up eating lots of kinds of chicken nuggets so that they can go anywhere and get them, or mom can buy them at home, or we get them to something that's healthier. We do this because a lot of kids see a different kind or shape or brand and say, that's not mine. If you just offer shoestring French fries instead of McDonald's, they will know right away, those are not my French fries. And so when we present one thing at a time, they only see what's different. And different is bad to kids. Different is not okay. They don't understand flexibility when they're younger, and food chaining helps work on that skill. And when we do it, we pair the food they like with the similar food to help with that visual discrimination, to help them see that they're not really as different as they think. So with this, we're gonna look at some of those sensory characteristics. I'm gonna talk to them about they're both round, they're both brown. I might cut the chicken nugget open and say, look, they're both white inside. When we're working with young kids, do they have the concepts of same and different or compare and contrast? Some kids may not, and so you're working more on the visual discrimination piece, but as kids can converse with you, we wanna see what their responses are to things being different. Note that there's a difference between processed foods and foods that you make at home. So when we want to practice with McDonald's nuggets versus homemade nuggets, they're very, very different. The texture of the chicken, the way the breading is, the shape and the size, the thickness. When we're using food chaining, we're taking very small steps in between things. So again, we meet that just noticeable difference. And I usually use as many, again, visual supports as needed. If they need pictures and charts, they need to be able to see modeling with us doing it. We want to make sure that they understand what we're asking. What foods do I start with? Foods that are similar to what they already eat. I may pick used to eat things, but I usually match by texture and color and shape to get started. Dips are and flavors and sauces are a really good way to chain. I had a child that loved brown sugar and cinnamon. And so we put that on a variety of different foods, all of his breakfast foods. We put it on apples and applesauce and pears. We eventually got to carrots with brown sugar and cinnamon on it. So you can use flavors to chain as well. I will always avoid any foods that have made them sick or something they show a really strong dislike for. It is not okay to force kids to eat foods that are really terrible to them. So here's a food chain that I've made for nuggets. Like I said, our kids are all addicted to McDonald's, and I might try other fast food ones. And then what our goal really is to things at home. So can we get white meat frozen nuggets? There's a new brand that has veggies in them that our kids are actually eating and liking. So that's a good way to go. From there, you go to something like a chicken patty. So it's still ground. The texture of the meat is still ground, but it's bigger. And then right there, we want to get to chicken tenders or strips, and something changes there. The actual texture of the chicken inside becomes more like regular chicken texture. It's not double ground. And so they actually have to do more work to chew and swallow. And so it's important that we work through that step and we get them to the place where that's okay. Can we make them homemade? Can we match that crunchy texture to what they like? Do we have to pound the chicken out a little bit thinner than maybe we usually would? Can we work towards fried chicken where the skin can come off and that they can start to get to the white meat and the crunchy part? Can we do baked chicken, like a shake and bake or a rotisserie chicken? And can we get to grilled chicken? So again, we want to see, can they acquire more than one food, or are we getting them to something that's a healthier version? Whenever we do food chaining, I always have the pair of foods available. I want them to see same and different. You're usually going to pick the food that they just, they're preferred with the next step up. Oftentimes, for consistency's sake, you want to pick the last one they tried with the next one so that they're still much more similar. One chain up there just goes from McDonald's fries to frozen shoestring fries to maybe crinkle cut fries. Steak fries have more potato in them, or smiley fries do. Working our way towards a baked potato. Mashed potatoes are a hard sell for lots of our kids, but that's the way that we're chaining. You're going to really monitor their refusal and sensory and anxiety patterns. What are they reacting to? What seems scary to them? What is the difference that they're reacting to? Do things need to be crunchier? Do they need to be softer? Maybe we find that we can only get through 2 or 3 foods in the chain, but we can't go too much farther. That's okay. We're just trying to see where they're getting stuck. You can use the steps to eating to work through food chaining. So you can do touch, smell, kiss, lick, bite with these so that they get comfortable and used to it. And keep track of their progress. Make sure that you're paying attention to how quickly they're going through these chains and what it is they're acquiring. One of the next things that's really important is to start working on generalization. And generalization means that we take a skill that we learn in one place or with one person, and we learn to apply it to other places and different people. And children have a really hard time with this, especially some of our children with autism or developmental disabilities, where they learn something for one person. And they don't know that what I do at school, I can do at home, or what I do in therapy, I can do at home with mom. A lot of kids say, I only eat for Dr. Brown in her office, and that's never my goal. My goal is for children to eat with their families. And we know a lot of kids do better for other people than their parents. And so sometimes as therapists, we want to work with the kids ourselves because we know we can make more progress. But the goal really is that the families are able to do what we do. And so we really want to make sure that we're working with families. We know that the home setting is different than our therapy settings. There's different rules and expectations. They know very clearly what I want in my clinic. I'm a new person. They only know one set of rules that I establish. I'm very consistent with my consequences, and things at home may not be the same. They go back home and there's all the old and familiar cues for refusal and disruption. That's why we start with a positive mealtime environment. That's why we start with parent education, so they can establish new rules and structure at home. That's going to make generalization easier. Sometimes they say that generalization needs to be learned in one setting before you learn in the next setting or person, but I think that we can program it early on so that it happens a lot more quickly. And we can teach them, especially the first place I like is visual cues. So sometimes I'm going to use a placemat in therapy that you can take with you to school, to a restaurant, to home. The placemat might have pictures on it of the food that we're going to try, the reward that we get, and where we sit and who we're with. So we can exchange those pictures based on where they go. And now the chart is the cue, not me or my office. We want to make sure that families participate in the process. So sometimes I'll have the family watch me do it, then they do it with me, and then they do it on their own. So that the families get blended into the therapy process as much as possible. Many times families will tell me that they've been in therapy, but they don't know what was happening because they weren't present. I strongly encourage you to include parents. If parents are having a difficult time refraining or not jumping in, that's when parent education has to come first. Then maybe you sit down and say, these are the things we're going to do. This is what I expect from you. Sometimes with parents, we just have them start with praising when they do a good job. Then we have them start to do the skills. Then we have them provide the reinforcer. So you can do it in a way that includes the parent, but you need to make your expectations clear for them and how you want to participate. Train different care providers, mom and dad and grandma. And usually if mom learns the skills with me, then I have grandma come in and learn with mom. And then when grandma does it with mom present, then grandma does it on her own. We need to really teach families to teach each other and to do this consistently together. We can train in different places. You can eat in your classroom or the cafeteria or in a restaurant. We can practice in McDonald's before we have to go to Applebee's. But teaching kids to do this across settings is really important. And one of the biggest ways that we generalize things is through reinforcement. So if I'm using toys as a reinforcer at home, we're going to use them at school. School's going to have different things they use as reinforcers, but we want to continue to reinforce that behavior across people and across settings. If mom's reinforcing with TV time after meals and we go to grandma's and TV is on all day, it loses its effect. Grandma has to use the same rules that mom does at home for generalization to happen. And it's the same with us teaching parents. I find that you as early intervention therapists have a very important and crucial job because you're at home with the kids and their families. You get to see firsthand what's going on, and you're catching children at a time where their skills are in a place where they can really bloom. And so I appreciate all of the work that you do and how difficult and challenging it is. And we're here to support you and give you any extra assistance that you need. Oftentimes, we know that you don't have the comprehensive team members that we may have here. We can help provide in-depth evaluations with research-based nutrition evaluations. We have lots of access to pediatric medicine and gastroenterology and ENT and an allergy so that we can help you round out the services that you're doing. We can assist with parent training. If that's a skill that we have and something that you're still working on, we can help make that happen. And we can also assist with blending any behavioral interventions with any other strategies that you're using. Our goal really is to augment what you do and to help move forward. So I just want to make a final statement about adherence to the guidelines. All early intervention providers must review and adhere to the New York State Department of Health Bureau of Early Intervention Health and Safety Standards, the guidance document when food is involved during EI sessions. Especially during this pandemic, we're taking very good care to make sure that we're wearing appropriate protective equipment. Right now, we're having all families interact with the food, and we are just providing services through telemedicine. But please make sure that you take the utmost precautions whenever you're interacting with foods and families. Here at the University of Rochester, we do have family-focused care, and we focus on having everyone engaged. Besides our dietitian and speech-language pathologist, we also have a social worker and a pediatric nurse practitioner. Our occupational therapists provide off-site therapy for children with sensory needs, and we do work closely with them. They're just housed in a different facility from where we are. And as early intervention providers, you're another spoke on our wheel. The community access needs to be a part of this. We need to add that within the services that we provide. Here on our team at University of Rochester, we do have 2 psychologists and 2 dietitians. Our dietitians are super helpful because they provide very in-depth nutrition analyses to identify every vitamin, mineral that the child has in their diet, to identify where protein comes from, where all their iron sources are, where they're getting their calcium from, and they help us make creative decisions in terms of how to get children to eat foods that they're deficient in. Our social worker helps us greatly to have access to services for families, for resources, and for dealing with difficult situations. And we have several students that work in clinic that are here for training and learning, and that do a really great job interacting with kids and families. To make a referral to our program, parents usually call to schedule that evaluation, and our number is listed there. They just ask for a feeding team evaluation. We determine what services are needed on the intake, but feel free to tell families what it is you're looking for when they come to see us. We're happy to have you attend visits as well. Right now that's possible via Zoom. In-person visits during the pandemic, that's much more difficult, and we're not doing those at this time, but if you want to participate, we'd love to have you. It's really good to meet you and see exactly what it is you're doing and see how we can share strategies. We can provide recommendations to you. We can share care with you. We can work with transfer of care. Whatever the family needs and you feel like you need, we're happy to help you with that. Our goal, again, is to collaborate and to work together. I've included several resources based on the things that we talked about in this program. The first article by Dr. Aponte looks at, is a good review article for parent training for children with autism spectrum disorders in feeding. Dr. Fraker's book is there as well, and also an article that came out with the early DSM defining what avoidant restrictive food intake disorder is. Other references from today's presentation are also listed at the end of this talk. I'm really thankful that you participated today. I hope that this was helpful and gave you some different learning opportunities for things that you can use in your practice. Note that there are other feeding programs across New York State, Syracuse, New York City, Buffalo, for example. All programs have different services. They all provide, have different care providers at their team. So it's always important to check out each program to see what you need. With telemedicine, we have a far reach, and so we can see families in Binghamton and Watertown, Elmira. We are available also if you need that service. I thank you very much and have a wonderful day.